Today is what I'm calling the foundations lecture. So it is just double click to make sure that audio is being captured. I think it is. Yeah, it is. All right. It's my fear is that I'm sitting here and it'll just be blank. So this is what I'm calling the foundations lecture. There are a lot of topics that you will hear throughout the quarter, and I want to really upfront tell you that when you hear a topic over and over again, it doesn't mean that it's repetitive. It means that it's reinforcing and that it's important. You'll hear FDA a gajillion times, maybe a Google number of times. You'll hear CDC, you'll hear AHRQ, you'll hear ISMP. Those are all alphabet soup acronyms, and that's one of the reasons why I have that governmental role lecture up front, because I want us to learn what they call the lexicon, which is the words that are being used. And so when someone says, oh, the ISMP recommendations, you're going to know what ISMP is, what they represent, what kind of things they put out, and whether that's relevant for what you're talking about. So that's an important component, so that this is a foundations approach that we're starting out with. These are the lecture objectives. A couple of things to highlight here. You will, so I like this. There's a word, okay. All of these verbs up here actually mean something, so they're tied to the way that items are written. So when I say, like number 6, evaluate a medication-related incident using the NCC MERP algorithm. We're gonna go through that in detail. I have an uploaded version of it in Blackboard. That's actually, I heard this year on the NAPLEX, not, like verbatim, but I got, people came back and they're like, Dr. Malcom, all that crap you told us was on the NAPLEX. And I'm like, for real? It's like I knew something about it, or like we're doing something in pharmacy. But that's actually what they had to do, according to what they told me, is evaluate an incident in a case based on this algorithm. So I was validated that I'd do this in class, but the adjectives, or sorry, the verbs and kind of what you do here is reflective of how the items are written. So we recommend using them for studying. If you're not able to do the thing that's in the objective, that's that might be challenging in terms of getting, the highest grade you want to get on the exam. All right, this is one of the curricula that I based the course off of. This is from the World Health Organization. They published this patient safety curriculum in 2011. I know that seems like a long time ago, and it is relative to today, but remember that this whole patient safety era that we're in started in 1999. So this was a kind of a culmination of the first 10 years of it. They haven't updated it a lot since then. It's a really well done curriculum. They've got like steps. It's applied across healthcare settings, and so I've used it for different purposes in terms of pulling material from it, and also pulling activities and things like that from it that could be helpful from a healthcare standpoint. All right, so safety in health systems. Unfortunately, I kind of alluded to that related to the different organizations that we serve. One of the major challenges is there isn't one organization that creates standards or guidance that everyone follows. There are organizations that touch on different things. An example of one would be like the Joint Commission, which you might have heard if you worked in a hospital. That's a hospital setting, right? So the Hospital Joint Commission doesn't accredit outpatient pharmacies. They don't necessarily accredit or even visit like doctor's offices. So all of those components are part of the healthcare system. They all have people that they report to. For example, in Kentucky, I did my PharmD in Georgia. The state has like a Department of Health or an accrediting body that will visit facilities, but that state, those state rules are different in Tennessee, Kentucky, Georgia. That's how states work. So there unfortunately isn't a great you're going to learn one thing that affects everybody. There are principles though, and there are things that are fairly universal. Example of that, you'll talk about formularies. So formulary is a good example of something. Every hospital has a formulary. Their formularies aren't the same, but if you go into a hospital in Oregon, if you go into a hospital in Florida, ask what their formulary is, they're going to have a formulary. So that is an example of something that might not look the same, but it has the same underpinnings to it. So the way that organizations go about choosing drugs for a formulary is generally pretty similar. So in that vein, the themes that we'll talk about are related to safety because this is a safety course. Examples, unit dose packaging. So is anyone work in a hospital, by the way? That's it? Anyone else works? Okay, I got three. Three hospital workers. All right, four, five? No, maybe like I don't want to be called out for it. That's fine. But these are, I understand, sorry, before I go forward, I understand a lot of you haven't worked in a hospital. I never worked in a hospital until we didn't have IPI, so I didn't go into a hospital as a learner until my fourth year of pharmacy school because we didn't have IPI. My very first rotation was in the intensive care unit at an academic medical center. You want to hear my trauma related to that led me to where I am today, more than happy to share it offline. But I was a fish out of water. And so one of my goals is to make that not the case for you all, but I realize it will be very difficult because you do not have anywhere to put that information. It's just very difficult to contextualize it unless you know what to expect. However, unit dose packaging are the little pre-made, if you ever buy like a thing of Tylenol or whatever and you rip it apart, that's unit dose, so it's labeled differently. As a forewarning, repackaging is a major component of your MPJE. I don't know why exactly because I feel like you would look it up, but they have to have something to write MPJE questions about, so they're probably my trauma remembering my MPJEs. I've taken 4 of them. I was like, am I going to be a repackager as I'm taking the exam? Because I felt like every question was about nursing home repackaging and bulk repackaging and things like that. But for those of you who've worked in a hospital, it is a big deal because you take some things come prepackaged. Some things are a lot less expensive if you get them in bulk and then you repackage them. But you have to do it correctly because the Board of Pharmacy comes in and inspects you. Another theme is computerized physician order entry, or CPOE. This seems, I know this is showing age. When I was in residency, which was about 15 years ago, we had paper orders and we had an electronic MAR. So actually they converted over to EMAR. Before that, it was like handwritten, and so once the patient got the med, they crossed it off. If we had to change dosages or change the time, we had to go to the MAR that the nurse had and manually strike it off. Now we don't do that. It's still something that the laws and rules are written around. So when you see CPOE, you're like, of course it's CPOE. Why would you do paper? You have a computer in front of you. But just keep in mind, a lot of people worked in both settings like myself. So they might not be as familiar as you would be because they lived in 2 different worlds. So they kind of straddle both of them as opposed to only living in a paper world or only living in a computerized world. I already mentioned the guidelines, protocols, and things like that. So you'll see themes throughout the material and really as you go throughout your practice and your training. Another, not necessarily one size fits all, but a concept is that there are different levels of error reporting. So error reporting is a big deal. When you think about errors, I think one of the goals for this course throughout the quarter for you all is to really flip your thinking about errors. Errors happen. Everyone makes mistakes. The people who don't make mistakes are the ones who are making them and covering them up or not reporting them. A hospital that has a low error rate is generally one that should be investigated for a cultural issue. Now, does it mean that certain hospitals are worse than others? I'm sure that that's the case. I'm sure that there are, situations in which there are actual differences. But reporting is such a cultural element. There's a lot of shame, there's a lot of blaming, and that is really not a good culture. I will definitely touch on culture as we go forward. We're going to hit it probably in almost every section, but it's something that starts, I think, with you all in the sense of making sure that from a foundational position, you understand that transparency and reporting is a component of it. I even go as far as when I'm working as a pharmacist at CVS, when a tech makes an error, when I make an error and the tech points it out, I thank them. I say, thank you very much. This is your role. This is what we're here for. When I catch something that someone else does, I say, hey, I just want to make sure it doesn't happen again. Those are things that culturally, if you reinforce how valuable they are, then the person's more likely to report it the next time. They're more likely to bring it to your attention. Do you want a person around you to bring things to your attention when they could hurt someone? I hope, because that could be you or your mother or somebody that you love who's harmed by that. And then the shame potential for like, oh, embarrassment, it's not really relevant when someone could really get hurt. That's not something that we want to either carry with us or something that we want the healthcare system to represent. However, just in thinking about it, there are different levels of reporting that are present. So I would imagine more of you, who works community in here, like Walgreens, CVS, Walmart? Maybe. All right, so when I will, and again, I'm not trying to bias, I say this every year, I work for CVS, so like I've worked for them for 24 years. That's my baseline of what I understand. I do know that they're not the only pharmacy though. So when I talk about things, just know that I'm talking about it from that perspective. The reporting system for errors internally tends to be different based on where you are. Not necessarily what they're asking for, but just the logistics of it. So there's not like necessarily a standard form that every community pharmacy fills out that asks for all the same information. Sometimes it's completely electronic. Sometimes it's paper and electronic or something you scan in. But that's an internal reporting system. So even corporations like that, even health systems that are big corporations have safety officers that are present. I'll talk about safety officers here in a little bit. That's what's called internal reporting. So those are not necessarily required in the sense of reporting out for public consumption. There are different accrediting bodies and state level organizations and accreditation that requires you to have an internal reporting system. It doesn't necessarily say what it needs to do though. On the external side though, there are certain things that are required. Talk about it a lot with vaccines here in the next couple weeks, but vaccines is a good example. So the FDA has a MedWatch system that handles reporting of medication-related problems, whether it's adverse reactions, issues with the package inserts of drugs, like things like that. But the vaccine system is a different system called VAERS. Vaccine Adverse Event Reporting System. I don't get too creative with the name. It's basically MedWatch for vaccines. All vaccine-related issues are required to be reported to VAERS. And so Walgreens, CVS, Walmart, whatever, they report their vaccine-related errors to VAERS. And VAERS handles all of that, vaccine-related issues. So that is maybe an example of something that is uniform. Everyone knows about and reports to VAERS. The way they do that might be a little different. I know because I've inquired about this at CVS. When we report a vaccine issue, we use the same portal and we just click that it's a vaccine, and then it goes to VAERS automatically because they've integrated their system with VAERS. And it gives you a confirmation that it was reported to VAERS and everything like that. So it's both of those levels have different roles and how they kind of work in that setting. But it might be called something different. Anyone work for Walgreens? Okay. The adverse event reporting system at Walgreens is called STARS. That is just when someone says, "Oh, I did a STARS report." If you were outside of it, you're like, "What kind of is it? Like astronomy?" Because you don't know the lingo, right? But STARS report is a adverse event reporting system. An error reporting system. So keep that in mind when you go and train at places when they say words, and I'm going to recommend this universally outside of this class. Anytime you're in an environment where you're trying to learn something and someone says something you don't understand, ask about it. Because odds are it's not going to come back around and it's going to come back and bite you. Because that's how pharmacy karma works, or educational karma in general. I say that about drugs. Like if you're working and you fill a prescription, I don't even know what that drug is. You're going to have an NAPLEX question about it. It's just the way it's going to happen. It happened to me too. It happens. Just trust me. All right. I mentioned that I'd come back around to medication safety officer. So this is a requirement, either de facto or de jure. De jure means that it's actual in the law. De facto means it's not in the law, but it's pretty much implicitly there. There needs to be some person or entity or office that handles medication errors in an organization. The Joint Commission has a requirement, and I've quoted it here: a clinical practitioner designated by an organization to serve as the authoritative expert in medication use. Doesn't that sound like it could be a pharmacist? I really hope it could be a pharmacist. It doesn't have to be a pharmacist. The place where I did my residency, the med safety officer was a nurse, but she was employed by the pharmacy department. So that was, it was involved with pharmacy, but it is an important role for the department or a individual pharmacist, depending on the structure. So that person reduces safety risks, meaning that they would look prospectively at things to see where potential medication-related problems could occur. They would optimize the medication management systems. And I know that sounds like 4 words that are just, what do they all mean together? When you go into a hospital, I don't know, again, like who's been in a hospital, who's like shadowed, that type of thing. It's a busy place. There's a lot of stuff going on. The meds don't tend to be out in front of everybody. They tend to be back in cabinets, drawers, in bins, that type of thing. But the way that a nurse or whoever's taking care of the patient gets to those things is the medication management system. How the medication goes from where it was, packaged and, dispensed to the floor. That's a part of the medication management system. So let's say that optimizing medication management systems is an abstract concept, but in the hospital, there is a ability for patient-specific bins. PSBs. Gosh, that sounds like it'd be logical. That means like if, I'm in the hospital and I have like Daniel Malcom's name and I've got my meds are in that bin. That is not standard everywhere. That isn't even always the desired way to handle things. Particularly if there is a lot of patients, because every patient would have their own bin. The analogy I can think about it is, what if at Walgreens, CVS, Walmart, wherever you work, every patient had their own bin? Oh, well, that would be a lot of bins, right? So that's how they kind of approach it. It seems logical, but it might not always be the best choice. So that's optimizing the medication management system. They would look, what are our potential error points? How many patients do we usually have? What's the general transit for them? Do they stay there a day? Do they stay there a week? Do they stay there 3 days? That does vary, because the meds are usually trailing behind the patient whenever they go from floor to floor or from unit to unit. Also, aligning their institution's practices with the National Performance and Quality Initiatives. That is another prospective, larger scale thing. So the Joint Commission has something that they call National Patient Safety Goals, generally issued every year, every other year, sometimes every 3 years. That is a requirement. So I was a part of a Joint Commission visit. Anyone been a part of a Joint Commission visit before? Wow. Okay. Anyway, it was terrifying. They put you in a room. I feel like it's like one of the rooms where the light dangles over your head, and they're like, "Tell me where you were on June 17th of 1975." Oh my God, I wasn't even alive. But it was adversarial, and adversarial means like they're trying to kind of see what you know and see how you perform, but not punitive. They want to know what happened. And I was a part of what's called an infection control tracer, which is where they take someone who came in with an infection and then they track their progress throughout the entire stay. So it was kind of neat because they interviewed the EMS people, they interviewed the ER, they interviewed the floor nurses, they interviewed the pharmacists, the providers, they interviewed the step-down units. And so my interview was about vancomycin dosing, because I had dosed the vancomycin for this patient. How did you go about doing it? What was your involvement? Okay, I mean, I was honest, I had been involved in it. We were on rounds, we talked about the patient, so it wasn't foreign. But it did make me appreciate what the systems do, because I actually learned a lot through that. They gave me the step-by-step of how the patient progressed. I didn't know any of that stuff, because sometimes when you're only a part of your little thing, you don't really see the bigger picture. But it did help me appreciate what our policies do, because I said, oh, I dosed it based on this, and this is our EHR, and here's how we handle this. We move the dose to this, this, and this, and so I reflected our institution's policies. So that was kind of an interesting way that aligned with my experience. I mentioned it's typically a pharmacist or a pharmacy manager, but it's sometimes someone else, but it's housed under the pharmacy department. So these are, these aren't the only ones because we're going to cover them next week. But the big three that I think cover a lot are the FDA, which approves drugs as safe and effective. Big buzzword there, safe and effective. Didn't always happen that way. They issue warnings and communications. So what used to be called black box warnings are now called box warnings. And that is when you open up the package insert, which I would encourage you all to do when you're at your IPI site. Just, they pop off the top of the bottle or the package wherever you are, open it up. They're all structured the same way. They're required to be structured the same way. They've got a table of contents. They've got all the different things. And so you can know where to look for things pretty quickly. Those are all things that are required by what's called the label. The label is that package insert. That's what is regulated by the FDA. And then also FDA handles MedWatch reporting. The reason why is because the reporting for MedWatch is related to the drug's approval from a safety and efficacy standpoint. Safety and efficacy are words you're going to hear throughout your training. Safety is, does it hurt? Efficacy is, does it help? Sometimes, though, there's a balance of those things because sometimes a drug helps more than it hurts. Sometimes a drug hurts more than it helps. Those are just really clear-cut principles that are relevant for what we do. The CDC is the Centers for Disease Control and Prevention. They don't have a P abbreviated there, so normally it would be CDCAP or something like that. But it is just it's headquartered in Atlanta. So if you've I'm a Georgia kid, as you know. One of the things I did in high school was we took a trip to the CDC to visit it. It's really neat. One of those things you don't necessarily get to do if you don't grow up in that area. But I didn't know it at the time that not everybody had access to that. So it was kind of a neat thing. It's really related to public health. And not just vaccines, although vaccines are a major component of public health. It's where it gets a lot of attention now. But if you go and dig into their resources, you'll see a lot with things like tobacco cessation, naloxone, which is prevention of opioid overdose and morbidity and mortality associated with that. You can see the themes when you go in. Oh, yep, that relates to public health. Oh, yep, that relates to public health. So next quarter, Dr. Leslie will be teaching you all in public health. You're going to be coming back to the CDC. There's a lot of things related to the CDC that cross over both from a safety standpoint and from a public health standpoint. Another mission component of the CDC is education of providers and the public. So there are, it's part of their mission. So when you go into the CDC website, generally, depending on what topic it is, there's like a for providers section and then a for the public section. So I tend to look at the provider section obviously first, but a lot of times if I'm looking for teaching materials, I'll look into for the public, things that could help, I think, both you from a learning standpoint now and things that might help you with your patients. Because if you're trying to figure out, well, how do I communicate this in the best possible way to my patients, sometimes looking at those resources that the CDC has, I mean, obviously they're available, they're there, and they're designed to be used with the public. So that pretty much aligns with what you would be needing them for. They're not always the best. They're not available in all languages, for example. Some of them are, but that's a free resource that's freely available. They also have, I think, a cool initiative called Protect, which is about advancing children's medication safety. It's comprehensive. It covers both legislation that the Poison Prevention Packaging Act, things like that, where you're required to have safety caps on bottles. One little side note, I did not realize this until a couple of years ago, but how do they decide that a safety cap is a safety cap? Does anyone know that? It's kind of one of those things that just says it's out there in the ether. Does anyone know that? I don't know if anyone's as curious as I am about things. They have these testing grounds for students that are for kids. So generally it's kids between like the ages of 4 and 8 or somewhere around that. They see if the child can open it in less than a couple minutes, sometimes less than 30 seconds to a minute. It's not an exact science. I thought it might be. Thought they might have a race to see if the kids could open it faster than an adult. But as you know, kids are real smart, really, really smart. So a lot of the safety caps, you just put your hand down and twist it. That doesn't take a lot for some kids. Some kids it does take a lot for. But that's it. It's kind of one of those things that something that's kind of abstract, like, oh, what does a safety cap mean? That's how they decide that. But this initiative looks at stuff like that and then also what drugs might need that in the future, what drugs that we already have on the market that might need that type of thing. So it's kind of a neat initiative. The last one here is AHRQ, which is called the Agency for Healthcare Research and Quality. It is a part of the Department of Health and Human Services, and its main roles, purpose, whatever you want to look at it, is providing grant money for research. So it takes money from Congress and it solicits grant applications, evaluates those, and then decides how to distribute that money based on priorities. So it also kind of as a product of that reports those results out. So if you get grant money from AHRQ, you then report your results back, and those become available on the website. Then a downstream effect of that is if you think about that happening over time, you get an aggregated database of potential best practices. One of the so next year in management, I will be teaching you all about team training in it's a pretty robust module. It's called Team Steps, STEPPS. It is a aggregated team training. It's like a comprehensive team training curriculum. It's on the AHRQ website. So that's an example of something that was a project that then made its way into something that's available on the website. So it's kind of a neat connection there. So those are the governmental groups. We have some major important non-governmental groups. Dr. Erringer is going to cover this also next week, but this is, again, foundational highlights. The biggest, probably most common one is ISMP, Institute for Safe Medication Practices. You can just hear that in the name. Seems like something that pharmacists would be either interested in or involved in. So it is a US-based nonprofit org, so it's not government, it's an NGO, but it's focused solely on the aspects of medication safety. There is a Canadian version of it, creatively called ISMP Canada. I actually do some peer review for both ISMP and ISMP Canada. I actually pull resources from both of them. They're all freely available. Things like the do not abbreviate list and some of the other guidance that they put out. They're slightly different, and sometimes it's based on practices. And the example I can think of from Canada is they have some French do not abbreviate things, which would be relevant for like Quebec. Versus we're not necessarily going to have the French angle. And then Quebec, if you're familiar with Quebec and Canada, everywhere the languages has to be in French and English legally. So I don't even know if they wanted to do that, but they had to. So it just makes the resources a little bit different. But I found that looking at both of them can be kind of helpful to think, oh, that's kind of relevant for us too. They also are the ones who manage the NCC MERP. I have a whole section of that towards the end of the material today. That is about error reporting. I've already mentioned and alluded to the Joint Commission. It used to be called JACO, Joint Commission for Accreditation of Healthcare Organizations, but they changed it to TJC, which I think is harder to say. And then now it's just the Joint Commission. They don't like being abbreviated. So it is a nonprofit that accredits hospitals and health systems. I think I mentioned before that, Joint Commission doesn't have a version for community pharmacies. That's not necessarily true all of the time because some healthcare systems have outpatient pharmacies. So they, by kind of, proxy default, have a role in accrediting that. But it's not necessarily just the outpatient pharmacy. They're looking at the whole hospital or the whole health system. Is anyone here from the West Coast or like the Pacific Northwest? Okay. Joint Commission is a major organization and it covers pretty much most of the U.S., but there are regional organizations that, especially out in California. California is it's a huge state, right? It's the most populous state. They've got a ton of hospitals and health systems. The Joint Commission is not as active out there. They have another organization that does that, but it's not as relevant for us in this part of the country, so we don't cover as much, but it serves really a similar purpose. Kind of like regional educational accreditors. There's like SACS, which is the Southern Association of Colleges and Schools, and then when you go across the river, Indiana, there's like a Midwest group. So it's kind of like that, just from a thinking about it standpoint. IHI is the Institute for Healthcare Improvement. They have actually gone through some different changes in the last couple of years. They used to have what's called the core curriculum for safety that was freely available to everybody, and I had you all as students in this class do some of the modules. They're very well constructed. They've got videos, activities, and stuff like that. They put it behind a paywall last year, and they reached out to me and they said, "Oh, we can get you a deal." I'm like, "No, if the deal is not free, then we're not going to do it." But I think it's a lot like things you see on computers and tech companies nowadays where they're like, "Hey, we'll give you this product for free," and then they just say a couple months later, "Hey, that free thing you got, we're gonna clamp down on it now." So it's unfortunate, but I've tried to take some of what I learned from it and apply it to what we do here. But if you are interested, there are still free available resources on that portal, particularly around some of the systems things. So I have a whole thing we'll do mid-quarter about systems thinking. But if you think about healthcare improvement, does not sound like the personal micro level. It sounds like the macro level. And so that's the way they approach it, is you are a part of the bigger system. You have your role, and the system has all of the people's roles. So it's kind of a neat bridge to that. It uses applied science also, which I think is, the Big Bang Theory fan, like Big Bang Theory. You always argued about science, like biology is applied, chemistry, all these different things. I kind of think about that when I hear applied science, but what they mean by it is they study systems and then they put that into practice. So they take, okay, this system works this way, and here are the levers and pulleys of this system. So we're going to experiment using those levers and pulleys to make changes. And so that's one of the ways that they implement their mission. The last one is the World Health Organization. I already mentioned the patient safety curriculum. What they do mainly is provide directives for international health practices. They're, just from a historical standpoint, a lot of the disease eradication that has happened in the 20th century, things like polio, smallpox, yellow fever, things like that, were led by the World Health Organization. So it isn't a perfect organization in the sense that it doesn't necessarily distribute resources equitably. There's a lot of funding issues with it, but it does have a great historical role for us to look at and think about, well, how do we get where we are today? Why is smallpox not a thing? Smallpox has killed more people in human history than lots of diseases. And why doesn't it kill as many people anymore, if any? And a lot of those efforts are the reason. So I mentioned this report already. It's a foundational report. It's uploaded. It's available. It's not necessarily required reading, but it is a lot of the background of where we came from. I love history. I'm a nerd in a lot of ways, but this is, I think, one of those documents that when you read it, you'll think it still resonates today. It talks about why errors happen, why we have to be upfront about them, and it talks about the role of culture. So I say all that because I'm segueing into the definitions that it uses. So these are in quotes because this is, again, since it was so foundational, this is where we get a lot of our definitions that we use today. Safety is freedom from accidental injury. What's important there? Accidental. Intentional injury, meaning like if I poisoned you, is not related to safety necessarily. It is related to me being a criminal at that point. But accidental injury would be something that was not intended. So a drug does something that we didn't want it to do. The healthcare system has a flaw in it that leads to someone being harmed. That's accidental injury. An adverse event is injury resulting from a medical intervention not due to the underlying condition of the patient. Again, medical intervention, which is called iatrogenic. Iatrogenic means like the medical system caused it. That is not due to the underlying condition of the patient. So if a person comes in and they have a life-threatening sepsis and they die of that sepsis, that's maybe a little bit of gray area because there are bundles that we could implement to improve their likelihood of mortality, but it drops the mortality rate from like 50% to 25%. So they still could die. That is not necessarily, that was not necessarily going to happen, but it might have. And so one of the things we think about with adverse events is if the person like dies of a gunshot wound, that is not due to the underlying condition of the patient, but it's also not a medical intervention. So there are different ways to interpret that. I think that's important though, because when errors are classified, and we'll go over that towards the end, you do have to think about what the patient came in with. And that came up a lot, I think, a couple years ago with COVID. One of the challenges with COVID was that it was a really nasty virus, especially early on. There was no immunity. I don't know how much you all learned about it at the time or learned about it since, but one of the major issues with it was when we as people encounter, our immune systems encounter something that we've not seen before, we don't automatically react to it. We don't generate an immune response because it doesn't stimulate the right components of the immune system to do that. That is the trade-off. So when you get exposed to influenza, for example, you have antibodies to influenza. If you've ever gotten vaccinated, you have some antibodies to it. Antibodies are like little things that connect, and they signal the immune system to react. The symptoms that you feel from a sickness are generally your immune system reacting to it. So if you've never been exposed to something, the virus goes in, multiplies. It is all over your body. It is everywhere all over your body, and you are not feeling anything because your immune system has not reacted to it until one moment the switch is flipped and your immune system reacts to it, and then it's everywhere. And then you get overwhelming symptoms, and that's what happened in the early stages of COVID. That's really why the mortality rate was really, really high at the beginning. All right, that being said, if a person has heart failure, diabetes, a lot of comorbidities, they're more likely to die of COVID. That makes sense. It becomes really difficult to tease out, was it the COVID or was it something else at that point? It just becomes a little more challenging. They weren't going to die that day, but they might have died a little bit later. So that's one of the controversies around it, but it is going back to that idea of how the underlying condition of the patient affects the way we classify errors. An error itself is the failure of a planned action to be completed as intended or the use of a wrong plan to achieve an aim. So there's two parts to that. An error of execution, meaning that you had the correct plan. I had this plan, lisinopril 20 is going in the bag. That was my plan. But I picked up lisinopril 40 and put it in the bag. That was a correct action, but does not proceed as intended. Error of planning would be, I see that. I think it says lisinopril 20. It actually says lisinopril 40. So I make this plan that was incorrect, and I execute that incorrect plan correctly. So those are very similar, but they're a little bit different because mostly you think about how you would manage the errors differently. So the first example I gave you is a process error. So that's something that you would look at, how did that bottle get in the bag? Versus the other one is more of a systems error because the interpretation of the order was the problem, not necessarily the process itself. It was a little bit different in how you would address it. The last part here is a preventable adverse event. So go back to adverse event. Preventable means that I could have seen it coming, or most importantly, I should have seen it coming, and that it resulted in some sort of injury to the patient. All right, what is a medication error? So there is no singularly recognized definition, but the NCC-MERP, again, we'll cover that towards the end here. A med error is any preventable event that may cause or lead to inappropriate medication use or patient harm while the medication is in control of the healthcare professional, patient, or consumer. I hate the word consumer in there. It takes away the whole patient-centered approach, but that's a big difference. Med errors happen in people's houses. They don't just happen in the pharmacy. So that means that we need to think about med errors a little differently than maybe you had thought about it before. Typically, or if you think about, before you might have said, oh, well, once it leaves our pharmacy, it's all you. No. Gosh, I really hope people don't think like that because, I could just do whatever with it. Give it to whoever and it doesn't matter. No, that's really, not thinking about the patient first. And so that's why this definition includes that. I'm not going to read that second part to you, but it does. Those are all of the things that definition kind of incorporates. And those are just parts of the systems. All right, so we said adverse event, and then now we say error. So what's the difference between an adverse event and an error? So let me, I like this chart here. Is this thing not picking up? It's not picking up because I probably talked too long. I'm a yak jacker, so let me over here. See if this works. All right, is that better? Yeah. All right, so an adverse event is this bigger outside box here, the dark blue up there. So we don't like adverse events. They're not desirable. We don't want them to happen. However, this is something that happens. So this is just generally something that happens. Sometimes there can be errors that don't make it to the patient, or that there is no adverse event that happens. So that is a distinction here, particularly when it relates to patient harm. So we're not necessarily going to be talking about this. We're going to be talking about the distinction of the stuff that's within this circle, or sorry, within this, whatever this is called. There are adverse events from an error, but not a drug reaction, meaning that it's not medication related, it's something else. So adverse event, leaving a towel inside of a surgery patient or something like that. That is healthcare related, but it is not medication related. There's an adverse drug reaction that happens without an error. You're allergic to something. They didn't know it, you didn't know it. I found out this summer I'm allergic to sulfa, Bactrim in particular. How did I know that? Broke out into hives. Didn't know what hives were necessarily, even though I teach it. I looked down and I'm like, those are hives, that's not good. And so I would fall into this. So I had to report it. I'm allergic to it now. But it wasn't anyone's fault. They didn't know it, I didn't know it. So that is not an error. If I had listed it on my profile and they gave it to me anyway without asking, that would be an error, and it would have resulted in harm. So again, going over here, the overlap is adverse drug reactions that are from an error. So this is the worst part right here. This is the example. If I have this allergy, it's on my profile, everyone should have known it. I'm dispensed, like I'm in a hospital and they give me Bactrim, and I then go into anaphylaxis. That is the center part here. They should have known, and it caused harm to me. That's a bad outcome. So I don't know if I'm hoping this makes sense, walking it through, like things can be in one and not the other. The example I just gave is an extreme example, but it's actually probably a pretty common thing we worry about when things pop up. Oh, you're allergic to this. Let me go and ask you a question about it. You're trying to prevent this awful outcome, which is I knew better and I didn't do anything about it, and something bad happened. All right. These definitions are, I've already explained them from the previous slide, so this is more of a written version of it. I will say, though, the difference between an adverse drug event, which is the harm associated with any dose of a drug, adverse drug event, harm associated with any dose of a drug, whether the dose is normally used in people or not. So an adverse drug event could be someone taking way too much of a drug, or someone taking not enough of a drug. It's any dose of a drug. A lot of our toxicity adverse events come from that. Adverse drug reaction, on the other hand, is harm that results from a dose that is normally used in people. That's important because when you go to the question like, well, how much were you taking? Oh God, 1,000 milligrams. That's way, way too much. Versus, oh, you were on a normal amount of the drug. Okay, you move on to the next thing. So that distinction from a classification standpoint could be important. Preventable ADE, harm caused by the use of a drug as a result of an error. Again, error being something that was preventable. Patient, an example, patient given the normal dose of the drug, but the drug was contraindicated. The example I gave about the Bactrim would fall under that. That's preventable ADE. Non-preventable ADE would be if I didn't know it. So that hives that I got this summer, when I didn't know I was allergic to it, that was a non-preventable adverse drug event. All right. All right, so so the other one wasn't quite a Venn diagram, but this one is a Venn diagram of errors, ADEs, no harm, non-preventable harm, and then preventable harm in the middle. All right. So now, this is another way to represent it. I won't go over that correctly. This is the same chart, but answering yes or no questions. So this is what they call a flow chart. Might be a little bit easier for you all as you're going back through it to distinguish between the things. All right, Another kind of interesting way to think about it from an error standpoint is classifying the errors that we make internally. So we as humans think about things before we do them. I'm saying we generally do. We don't always think about things before we do them, but sometimes we do. So errors are when actions are intended but not performed. There are differences between mistakes and skill-based errors. So a mistake is when, as we discussed earlier, you plan to do it wrong. So I'm doing something or wanting to do something and my plan is not carried out effectively. But the plan is the problem. Skill-based errors are when the plan was fine, I just didn't execute it. Sports fans, got sports fans in here? Play calling versus play execution. That's what that means. So I'm a Georgia fan. Georgia fans notoriously hate all of our coordinators. Defensive, offensive, special teams, doesn't matter. We hate them. And it's always their fault. Well, when the receiver drops a pass that was in basically to his numbers, like right on his chest, that's not the coordinator's fault. You know, that's an execution issue. So that's the way I think about it. It's the way my brain wraps my head around it is play calling versus play execution, or planning versus execution. So this is a way to classify those things from a technical standpoint, but this is one of those things we will distinguish throughout the quarter as we look at errors in general, is was the plan a good plan or was the plan not a good plan? And then if it was a good plan, was it carried out effectively? All right, last thing before we take our break. The Swiss cheese model you're gonna hear about throughout the quarter. So this is one of those things that, has anyone heard of the Swiss cheese model before that happened? Okay, awesome. So it covers a lot of different areas. You might have heard about it in other science classes, whatever. Actually, again, not that old, comes from 1990, British researcher. So the theory here is that we have these hazards, or what they call latent conditions, things that are just present. Example, it was raining this morning, right? It was raining for everybody. Everyone's in the same boat. Now, are some people better drivers in the rain than other people? Probably. Probably no data behind that, but let's say that they are. Are some people more apt to be careful in the rain than others? Yeah, I would say that. That's a hazard, right? Those are latent conditions. Those present for everybody. So in aviation, think about fog. The weather is a big deal. So like whether the pilot can see, that type of thing. And I'd say the same thing for drivers. Those are hazards. Now, there also could be other things that are present, meaning if you're angry, you just got into a fight with your spouse, your kids, your friends, your roommates, whatever, and you get in the car and it's raining. That's two things that you got to fight against to be able to drive safely. I turn on my radio, loud as I can get it, on heavy metal. That's a third thing that you got to fight against, because you're not going to hear a siren going down the road. Let's say then you want to make a left-hand turn across a major road, like a major Selbyville Road at, 8:30 in the morning. That's a fourth thing that you got to do. All right, loud music, but okay, you've got a lot of problems. You've got a lot of things you got to fight against, and you're everything you add to it is tempting, right? You got your phone, it's all just adding up. Now the problem is these are latent conditions, but you do have barriers to protect yourself. You've got maybe nudges. You've got a person saying, "Hey, drive safe." Your mom calls you, "Hey, make sure you drive safe this morning." That's a little nudge. That's a little I should drive safe. That's a little bit of maybe help, a little protection. That could help you. Now, what if you say, "I don't like her anymore"? That's a hole in the Swiss cheese, because that system did not help. My car has the steering wheel adjustment thing. Good until the little green light goes off, because it can't see the stripes on the side of the road. Well, if I rely on it and then it's not there anymore, then I'm not driving it safely right. So that could be another hole in the Swiss cheese, because the steering protection is a slice of the cheese. So if you go down here, these can be called either passive failures or active failures. Active failure means I've turned it off. That's an active failure. I didn't like it. I don't do it. I don't participate in it. But essentially, an adverse event is when all of the holes line up and you get an event that happens. When you have something happen, 9/11 was a good example. Probably a lot of you are not born. He was born after 9/11. My niece is about to graduate high school. We had this conversation. She was born in 08. All right, I'm old. But 9/11 is a good example. They did a post-action report of what happened. So you could line this up. Here's a hole, here's a hole, here's a hole, here's a hole. The president had intelligence that was not valid, and all these different things. Everything had to work out exactly correctly on the day of. Those are all things that lined up for the events to happen. You could argue that some of them would have been worse or better or whatever, but the same model still falls into place. So we can use that across systems. So I would imagine those of you who've heard of it before probably didn't hear about it in healthcare, probably heard about it somewhere else, because any system has Swiss cheese, and then the holes could line up to have something bad happen. All right, let's take our break. Let's come back. Let's try to come back at about 10 after. So let's say like 7 or 8 minutes. Appreciate it. What's wrong with the dang air conditioning here? I don't think it's working. All right. Let's go ahead and start back. Sorry. I was having trouble with my laptop here. It was being persnickety. Okay. I think I might have to stitch these recordings together on the back end because it may not have, it may have split. I uncoupled the computer from the recording thing really quickly, so it kind of did not like that. All right, so let me go back here and all right, so oh shoot, I don't have another do I have a USB charger? Just like I can plug this mouse into. Well, otherwise I'll see if it lasts. If it doesn't, we'll just have to go from there. All right. It's just the trackpad that doesn't work. I'd have to oh, thank you. I have to reboot the computer. Yes, that works. Thank you. All right, so going back, where were we? Shoot, I'm sorry. All right, so we talked about that part. All right, so I've already gone over the different components of it. So now we're going to talk about how we classify errors. So this is the kind of getting into the action-based components of the material. The medication use process you will hear throughout the quarter. If you haven't already heard it, there are 5 main steps to it. Some of them have just slightly different wordings depending on what setting you're talking about, outpatient versus inpatient, that type of thing. Ordering, transcribing, dispensing, administration, and monitoring. Administration being the one where in the hospital setting you might not, or sorry, in community setting you might not be the one administering it. The patient is administering it to themselves. So like if they take it incorrectly, that's where that place in the, or that's where the error occurred. Importantly for us, errors can occur in any step or multiple steps of the process. Sometimes errors can circle back on themselves and even end up with a not error happening, meaning like one error can happen and then another error happens that almost addresses it or fixes it, but didn't intend to do that. So generally, when we think about the types of errors, the kind of stuff we think about is like wrong patient. So if I'm at Walgreens or whatever, and I'm John Smith and I get John Jones prescription, that's like a pretty basic error. It's not good because that's an error, but it's what we tend to think about. Wrong dose is another one. That's one that I think might be a little harder to sometimes tease out because, like, let's say that a patient has a new prescription and the dose is lower than it was before. Is that an error on the part of the prescriber? Meaning, like, did they send the wrong dose? Is the wrong dose the current one? Meaning, like, do we have on file the wrong dose and the patient's supposed to be on that lower dose? We don't always know. that can be challenging. So we have to involve the patient. Sometimes we might have to call the provider, that type of thing. Inappropriate medication. So a patient gets, trying to think of something easy textbook-wise, like they're on a nitrate and they get prescribed something like sildenafil, which is a PDE inhibitor for like erectile dysfunction or pulmonary hypertension. That's direct contraindication. So that is an inappropriate medication for that patient. So I alluded to this before. This is actually from the New York Times, and it talks. I mean, I don't know. I just think about like, wow, when I see these things in public, like out in the general media, I'm like, oh my gosh, wow, okay, well, I'm reinforced that it's something really important, I guess. So this is from the early in the pandemic. So the Swiss cheese respiratory pandemic defense recognizes that no single intervention is perfect at preventing the spread of the coronavirus. It's exactly what we were just talking about. So you've got a slice, right? So physical distance, stay home if you're sick. You can't infect someone if you don't get in contact with them. Hand hygiene, cough etiquette, crowded. If it's crowded, limit your time. That's another layer. Ventilation, outdoors, air filtration, potentially quarantine and isolation. Those are all layers of the Swiss cheese. If, as you progress forward, you might get caught, right? So like this hand hygiene might be the thing that prevents you from getting an infection or prevents it from spreading. But it could go all the way down. So on the bottom, they list out what are the tools that we use for that. So hand hygiene, cough etiquette, masks, avoid touching your face, fast and sensitive testing and tracing, meaning like you don't delay it because so you actually know that you have it, therefore you can know to take all those actions and that type of thing. Vaccines being another layer of defense. This is one of my tools that I talk about when I teach or talk to patients about vaccines. Why would you want to get a vaccine? It is literally another layer of defense because your immune system then gets a heads up that something is coming. It's not always fun in the sense that the earlier you have an interaction or a reaction to it. I get pretty sick with the flu. I'm a baby when it comes to that kind of stuff. Just a pesky Y chromosome, I suppose. But it knocks me on my butt. Knocks me on my back. Guess what I'm not doing if I'm in my bed? Transmitting it to other people. So honestly, in a way, getting sick with an infection is a way to prevent it from spreading. Now, I try to think about that when I'm doubled over in absolute horrendous pain or whatever. I try to think I'm like not transmitting this to other people, but it doesn't make me feel any better about it. We don't, hopefully as humans, want to transmit diseases to other people. So I think that's another kind of backdoor strategy to teach people about it. All right, we're going to talk first about something called the failure modes effects analysis. All right. So I mentioned before that when you are planning something out, so if I'm planning, we're opening a pharmacy, and I'm looking at how the pharmacy is designed. All right, so I have you walk through the workflow. I'm like, all right, take this, hand it to the next person, hand it to the next person. Where am I involved? Where are you involved? How do we get the prescriptions from them? That's a prospective analysis of looking at where errors might happen. Now, if we did that, that's an actual exercise, and it's called Failure Modes Effects Analysis, FMEA. It is a very common strategy that has a bunch of different names. Workflow analysis is one of them. If you all anyone Chick-fil-A fans? Like they're like the workflow masters. I mean, if you go in there and you're like, this is like an airport. I've never seen anything like this in my life. Everybody knows what's going on generally, and they have a place for everything, right? They did this. It's not healthcare related, but they did this. Like, where are you at this point? Where are you at this point? What is farthest away from you? If I have to go over here to get the lemons, I'm bumping into people, I'm causing a delay. They're prospectively looking at every step in the process to see where they can either cut time or maximize efficiencies. In healthcare, in this type of analysis, we're looking at every step in the process to see where errors might happen and what strategies, tools, any type of approach can be used to prevent those errors. So unlike general incident reporting, meaning like, well, we'll just wait and see what happens and then we'll address it from there. That is retrospective analysis. We'll talk about that here in a minute. But there is value in both, and the value prospectively is I could have anticipated it happening. Value retrospectively is, oh gosh, I could not have anticipated that particular thing happening in that particular way. That is not something I would have anticipated. If I only did prospectively, I don't have the ability to go back and look at it after the fact. If I only did retrospective, I should have known to anticipate this. So just like we're talking about strategies to prevent errors, you know, using two names or using two ID forms, whatever, this is a general process that's used for that. So another thing, we're going Murphy's Law. Murphy's Law is just whatever can go wrong will at some point go wrong. So if I'm saying like, all right, I've got my system here, and my pharmacy system requires two forms of ID. So again, CDS is my, you want to work for CDS or, so we have name, date of birth, or name, address. The system will not find the person, which is interesting. The system will not find partial matches. It will not find the person at all if you don't have the first three letters of the first name and the first two letters of the last name. Now that could be like MacDonald, MAC versus MCD. If it was MCD and it's MAC, it doesn't find it. So I'm like, how do you spell that last name? I don't, when I ask people that, they're like, are you stupid? I have to say like, our system only finds people if it's got the first three letters of both the last name and the first name. So that is a very important tool, right? What if my system allowed me to bypass that? That's a hole in the Swiss cheese, right? That's a potential prospective error, causing thing. So that's the type of FMEA analysis. You're looking prospectively at what can be overridden, where, and what the consequence of that is. So let's say that my system has a safeguard that if things are overridden at the register, it prompts the pharmacist to come over, and that's a safeguard, right? That is a way for the system to find the medicine, but then have another safeguard in place. So I could plan that. I could address that in my design. So this is where, this is kind of, I mentioned that it had a structure to it. There's a lot of science behind this. So this is, again, one of those applied sciences. You have the failure mode. So failure mode effects analysis. That's where it comes from. Failure mode, what could go wrong? Failure causes, why would that failure happen? Failure effects, what would be the consequences of the failure? Those are really three important components to it. Then I rate the likelihood of occurrence, meaning I look at perhaps how many, so if there's a prescription, how many prescriptions per day, if it's like the register, how many prescriptions per day are picked up? What is the general volume? And then based on perhaps a previous error rate, I would say, okay, that could happen maybe 14 times in a day, just making that up. That could be compared with something else. This may be, okay, this is related to refrigerator minutes. Well, we don't have as many refrigerator medications, so that's less likely to occur. So I could compare those types of things. Likelihood of detection, that's a big one. I think if someone gets the wrong medicine, that's a high likelihood of detection. I hope so anyway. Some things are not though, right? If it's lisinopril 10 versus 20 and they have both at home, they might not know, right? They might take the old one, they might take the new one, they might take them both together, who knows? So that might have a lower likelihood of detection than something like a wrong patient. Then the severity. So all these are 1 to 10, so 10 being most severe, and then you can rate them comparatively. The risk priority number is those three values multiplied together. Cool. So that is then how you rate all the things you want to do. Because at that point, you have a stratified, sorted list of things that you can do based on the likelihood of occurrence, likelihood of detection, and then the severity of it. So that I think is a neat way to like kind of make abstract things more concrete and understandable is when you do these types of analyses. So this is an example of one. There's templates available online that program or institutions can pull. If you're designing something prospectively, this is a great. I mean, honestly, it's useful everywhere. If you're looking at like a kitchen. I mentioned Chick-fil-A, but if you're designing something prospectively and you're like, I want to make this as efficient as possible, this is a great way to do that. Here's an example of one that's I pulled. So the steps in the process, the failure mode, I'll just read through this. The first one, orders are written for new meds. The failure mode, the first dose may be given prior to pharmacist review the orders. That's not uncommon if it's something that's available in their AccuDose or in their Pyxis, which is the automated dispensing cabinet. The failure causes. Medication order may be available and easily accessed in the dispensing machine. That means that the medication's ordered, there is very little oversight between the med ordering and the first dose being given. That is a potential for error. Failure effects, patient may receive incorrect medication, dose, or dose via incorrect route, because none of that is being checked, which is part of the pharmacist verification process. Likelihood, and this is just how this is rated. 6, likelihood detection 5, severity 1, the RPN is 30, and then actions to reduce occurrence of failure, assign clinical pharmacist to the patient care unit so that all medication orders can be reviewed as they occur. So that would be an example of a just basic process. So you can sort by any of these. You can like sort by this column, that column, or the general column. And then you can look at, you could actually then do a sub-analysis of the cost of these things on the back end of it. It's not necessarily related, but it could be something about the logistics side of it, because I would imagine assigning a clinical pharmacist to a patient care unit is a pretty substantial cost. And so you would need to make sure that it was cost effective if that was one of the things you were looking at, but it isn't necessarily related to the safety side of it. All right, so I mentioned prospective. That's prospective. Now the retrospective side, from a yin and yang standpoint, got to have both. A root cause analysis is when something does happen, we look backwards at why it happened and what we can do about it. So it is always used after an event. Now, again, if you only do that, that's a really bad circumstance to be in, because there are things that could have been foreseen and prevented. It also, just like FMEA, can be used in areas outside of med safety. So not just in the hospital, not just in healthcare, even aviation uses it a lot. Any type of systems uses it a good bit. It is kind of interesting that there's a lot of analogies and overlaps in the things we do every day. I'm gonna go back to sports. Sports is where I get a lot of my analogies from. Kickers, at the end of a game, get a lot of flack. You know, they get a lot of flack. It's a lot riding on their legs. They miss a kick and they get like, I mean, there was movies have been about it, right? Like, I mean, one of the Ace Ventura movies was completely about laces out on, you know, like a football. No one talks about what got the team in that position to need the kicker to save the game. That is a lot. That's putting all of your eggs in that basket, right? We're burning the boats. We're putting all of the weight on that kicker's leg. That kicker then gets all the attention, but no one talks about what the team did before that to get the kicker in that position. I say that because the root cause analysis tries to get past that. What the root cause analysis says is, where in the steps in the process did this error become inevitable? Meaning, where were there no further opportunities to potentially prevent it? That then is the root cause. So kind of in an example, so let's take that example from the FMEA, where the first dose of a drug is ordered and then it's gotten from the automated dispensing cabinet. There's, I suppose, 2 places in that example where the error could have been caught if the error was grabbing the wrong med. There is the med system itself, meaning like if you have to type it in and then maybe ask you a question, are you sure you want that medicine? That's called a nudge. We get that a lot now with our computers. Like, are you sure you want to do that? Are you sure you want to delete that file? Thanks. Actually, I did not want to do that. I appreciate it. Or, yeah, I'm sure, right? That's a nudge, and that's potentially one. The second one is in the actual machine, grabbing it and giving it to the patient. So that's a little more abstract, because the nurse, again, whoever it is in that situation, is the one who goes and grabs it. So that's one person doing it. I think about that when I'm by myself at the pharmacy, because I try to like do something and then go away and come back, because then I'm a different person. And so I'm like, oh gosh, wow, that was wrong. Thanks, self. But if you don't take that step and you're by yourself, then you could have problems, because you're biased, because you saw it first. You know, you're the one who thinks that was the right thing. You don't know what you don't know in that example. So the root cause analysis would go back and say, perhaps the first one would have been the time at which it was inevitable. So the system, after that was bypassed, after they said, yes, I'm sure, that was the root cause of it. That could be in that example. So another way to think about it from our model, Swiss cheese, is which layer of cheese was the one that was the last line of defense in that, where did the hole go through the last time, and then the loss occurred at the other side of it. All right, we've got 6 components to a root cause analysis: communication, environment, equipment, barriers, rules, policies, and procedures, and fatigue and scheduling. Those are all related in the sense that they all are relevant, but they're not all the same. So the goal, overall goal, is not just to find out why the thing happened, but how we can prevent it from happening again. I kind of alluded to that just a minute ago. The strategy that it uses asks why at each level of cause and effect. So why did the thing happen in the way it happened at that time? Here's an example cause and effect diagram. This is pretty small here. So I would encourage you to go and look at this on your own, but it's got the problem, it's got actions, conditions, so those kind of related to the layers of Swiss cheese. What was something was changeable, what was not something that was changeable. It's got different choices, meaning like where did someone make either binary choice, I went this way, I went that way, I picked this thing, I didn't pick that thing, and then what the cause of it was. So those are related to those 6 areas. Fatigue and, I'll just throw an example. Fatigue and scheduling can be something that's a lot more difficult to quantify. But you'll find throughout the course, I'll go back to aviation a lot because there's a lot of overlap there. One of the things in aviation that they look at is when the pilots are fatigued, then they make worse decisions. There's actually really solid, reliable, repeated, like duplicated data about people when they're sleep deprived. That's one thing, talk about sleep. They make decisions on the par of people who are intoxicated. The longer the sleep deprivation, the comparative higher the intoxication level. So we don't say, don't drink and drive. It's don't not sleep and drive. Like that should be just as important because we make the same types of decisions the longer we're sleep deprived that we would make more intoxicated. I ask you that. Would you go and get intoxicated before you took an exam? That's a no. If anyone's hesitating, that's a hard no.
I think
hard pass. But a lot of people stay up all night, maybe 2 nights before the exam. You make really, really poor decisions at the level of being intoxicated. And you drove in, arguably, to class after not having slept for forever. So I would encourage you to look at this. It's as an actual example, so it's a real kind of like physical example of it. This is an example flow chart. So what that was like a concept map of all the things that were involved in it. This is asking those questions. So this is saying, all right, patient has COPD and is on oxygen and requires knee surgery. JP could have had his oxygen therapy DC'd for the duration of the MRI scan without causing complications. So this is like what happened and then what the consequence of it was. And so each step in the process is, going back here. Each step in the process is what happened and then what the result of it was. And so this is asking why, that why question. Event, why it happened. Event, why it happened. Event, why it happened. And so that's how an RCA is conducted. Another one of those things that I got to be involved in when I was in residency was the root cause analysis. It wasn't a great thing. We had a patient who almost died. They qualified as an event that needed a root cause analysis, and I happened to be on my med safety rotation that month, and so we got to be involved in it. But I was kind of like an investigative reporter almost, just asking objective questions. Why did this happen? Why did this happen? And I mentioned culture before. It was like crickets talking to people. Even though we kept saying like, this could happen again. We do not want it to happen again. Everyone agreed we don't want it to happen again. So that's a really potentially big barrier to overcome. And it just persists. It just stays out in the zeitgeist that people are afraid to report things. So this is one of the objectives distinguishing between root cause analysis and FMEA. So again, root cause analysis is retrospective, FMEA is prospective. So retrospective after the event, prospective is before the event. And again, before the event's a lot more difficult, but it's important because there's lots of things that could have been prevented. The example I gave before of like how easy is it to turn off your safety systems in your car? That's kind of an FMEA thing. If it's super easy, there's an aviation example where there was a plane crash that happened where one of the safety systems called the Traffic Collision Avoidance System, or TCAS, was malfunctioning, and the fuse to disable TCAS was right behind the pilot's seat, and they just pulled it out every single trip to be able to continue to fly. Well, they had a mid-air collision. So that was obviously the pilot choosing to do that, but the ease of which it could be done without having a second person look at it, without alerting anyone else, without alerting someone else, was part of the analysis. And so they prospectively did not look at that in terms of the potential ease of it happening. It's a retrospective thing. But there was value in that, given that they can prospectively in the future design the systems to have more safety involved in them. All right, so this is the last thing that we're going to cover today. This is the error classification. So NCC, the National Coordinating Council for Medication Error Reporting and Prevention. They need a better name. NCC MERP is really a mouthful. I need to come up with like the zebra strategy or something like that, because this is not glamorous. But the good thing about it, from our perspective, is that this gives us a uniform way all pharmacists across the country and in Canada use this classification system. It's on the NAPLEX. So pay attention. This is the most widely used system, and in fact, when errors are reported to ISMP related medications, they're going to ask for all these details. So even if you didn't do it, you're going to have to do it, and they actually walk you through it. It's kind of one of those things, they do the flow chart with you. So at the end, you did it, but you might not even know you did it because of the way that the flow chart was constructed. So it has benefits. The benefits were what I just laid out. Everyone uses it. It's pretty straightforward. The limitations are that it's user generated, meaning that there isn't a person coming behind whoever's putting it in or analyzing it systematically to say you did it correctly, you didn't do it correctly. It's a lot like adverse event reporting when it comes to clinical trials. So one of the things that's challenging in a clinical trial is either you ask the patient what's going on with them, meaning they just report everything, or you're asking them specific questions, meaning like, do you have a headache today? Versus, tell me all of what's going on with you. Those both are strategies used in clinical trials, and they both have ups and downs. They both have benefits and downsides. So again, kind of one of the challenges that's embedded in that is all errors are not reported because they have to be detected. Someone has to go through the process of reporting it, and that can be laborious. In fact, lowering the barrier for reporting is a potential strategy that needs more attention. Another aspect of it is that not all of the components are entirely objective, meaning that they're not all verifiable. How much harm could have occurred? That is somewhat of a guessing game. The examples I just gave you of like the last step at which something could be caught, I'm not sure if you picked up on it, but I said that getting the drug out of the automated dispensing cabinet was the last step. Not really, because the nurse could have identified that they were doing the wrong thing. I kind of skipped over that because it's a lot harder to prove that component. It's a lot harder to verify. It is subjective. And so I classify the error differently maybe based on my interpretation of that last step. Maybe I was having a technological or technical analysis versus a human factors analysis, which is the person's choices. And then incidents versus errors. So we talked about before about adverse events and then whether or not someone could have known about it. Here's an example. Let's say that the person was transferred from an outside hospital and they were transferred into a medical system that uses something like Epic, but the outside hospital did not use Epic. The allergy, maybe it was me, and I was at King's Daughter. I was making something up. I'm not from here, so don't get offended. I'm at that hospital. I've got that Bactrim allergy on my profile, right? It's printed out and it's embedded in the paperwork. When they get to the hospital, they just give out a report, right? What if they don't say that in the report and it's buried in the notes? Where does that fall? Is that a should have known? Maybe. That's really where the subjectivity comes in, because I could make an argument that it was not possible to know because the systems weren't communicating with one another. I could also make an argument that the systems could have been improved and that could have been preventable. So I hope that's my way of explaining. Sometimes things can be a little nebulous, but your exam questions won't be, and the NAPLEX questions won't be. But when you do it in practice, you might find this is a lot harder to do because you don't have all the information that you need. Time and complexity. So going back to the example of not all errors are reported, I would make a bet that not in particular all near misses, maybe very few near misses are reported. Now, what's a near miss? Y'all know what tell me what a near miss is.
It was almost a problem.
So I'll give you an example. So let's say that you're driving too fast and a kid runs out in front of you because you're speeding through a school zone. And you slam on the brakes, you don't hit the kid. That's a near miss. You very well could have hit the kid, but you didn't. Hopefully you understand then why it's important not to speed through a school zone. It's not because it's illegal, because you get a ticket. It's because we don't want to run over children.
Wow.
I don't want to run over anybody, much less a kid. Okay, so then that example is something where I'll give you two parts of it. One of the major challenges with our brains, and this is related but not necessarily related. Our brains are really poor at assessing the chance of something occurring. I'm going to talk about it with cognitive biases, but I'll bring it up here also. People are deathly afraid of dying in plane crashes. I mean, I don't say deathly afraid. That's probably not the right way to describe that. Very afraid. Okay. The likelihood of you dying in a plane crash, infinitesimal. Infinitesimal. You're probably more likely to get struck by lightning twice in your lifetime, or something like that. Lightning strikes are far more common than people realize, by the way. Actually, very relatively in particular common. But when incidents occur with plane crashes, they're really dramatic. There's a big investigation. It makes the news. It stays in the news for a while. But if you look at the news on a daily basis, you are far more likely to die in a car crash. Far more likely to die. I bet everyone here knows someone who's died in a car crash. Who knows someone who died in a plane crash? Let's think about that for a second. All right. So taking that into consideration, one of our challenges is that when we have near misses occur, let's say that in that school zone example, we don't hit the kid, but we're like, man, I'm a good driver. Next time I'm going to speed through a school zone, and I'm not going to hit the kid because I didn't hit it this time. I didn't hit the kid this time. I got my driving down. I got this down. That is what's called a near miss fallacy. It is a near miss bias. When we have things that almost happen to us but they don't, our subconscious gets incentivized to do it again, and do it again, and do it again. It becomes almost a dopamine hit because we're getting close to being, it's that risk, it's like the kind of implicit risk assessment that people have. They skydive. Well, we didn't die this time, so, ooh, it was exciting. Didn't die next time. Ooh, it's exciting. You know, that's not the same thing, but it is kind of, it's kind of like a proxy for it. All right, that then goes to whether or not they're worth reporting. Here is another example. If you have a technician who makes errors regularly and you always catch them, those are a bunch of near misses. You need to address the challenge. You need to address the problems before they become a more major problem. I mentioned before, like, I thank the technicians for helping me, but I look for ways to not have it happen again because I don't want the technicians to have to do it again. I want them to catch different things that I'm doing, not the same thing I'm doing again. So when you find someone doing the same thing over again and you didn't address it, that is why near misses are worth reporting, because the next thing might not be a near miss because the person's incentivized, whether they know it or not, to continue to do it because they're going to be caught by it. Another example of that is seatbelts. So there's a whole, this is a historical thing. When seatbelts became common, and I go back and I'm like, God, in the 60s, my grandmother and my grandfather were ejected from a car. After the first one, you think they would have said we shouldn't be doing that anymore, but it used to be super common to be ejected from a car. So people were afraid of driving at that point. So then once seatbelts came into play, though, people started driving more recklessly, which is crazy, but they did. And that's one of those paradoxes, if you kind of think about it, is safety procedures make us more likely to make different choices. The steering wheel example that I had, I was in Georgia last week with my family, and I was driving my dad's truck. It doesn't have the correction, and I noticed it. I noticed it already was affecting my driving because I was not as attuned to where I was in the steering wheel because my car does it for me automatically. And that was just an awareness thing, right? Like I noticed because the steering wheel doesn't move itself in that car. So, it's just something to keep in mind when we're looking at near misses is how does that work in our brains? How are our brains trying to trick us? And then because of the reporting and because of the challenges of all that, it's hard for us to know what the actual error rate is. So this is the algorithm. I'm going to go through each one of these, and I'm going to go through an example. So they're color-coded, but it's less helpful than you think because most of them are orange and yellow. A, B, C, D, E, F, G, H, I. A is the least harm. I is the worst harm. I don't know why I is green. It should be red, I think. I don't know why it should be like A is green, but then also that would, anyway, that's just whatever. It's color-coded. You don't have to agree with it. Green is error death. So they are progressively worse, but the difference is what interventions were required and what harm occurred. Meaning, if you had an intervention and it saved the person's life, that is less severe than if you had an intervention and it didn't save their life and they still died. So going through this, I won't read these to you because I just kind of talked about it in general, but the examples on that third column are just kind of like prototypical examples that might fall under each one of those categories. Here's the first scenario. 25-kilo child with no prior history of penicillin allergy was prescribed 250 milligrams orally of amoxicillin suspension twice daily, morning and evening, for 7 days. On the 7th day, the child inadvertently received a morning dose of 500 milligrams instead of 250. The child did not suffer any negative consequences from the error. So I've got a lot of information there. Now we're going to ask ourselves the questions in the flowchart. So, did an actual error occur? So did an error occur, yes or no? Yes. So we go down. Did the error reach the patient? Yep. So we keep going. Did the error contribute to or result in patient death? No. Was the patient harmed? No. It said they weren't harmed. Ba-ba! So was an intervention to preclude harm? No. We didn't have to do anything. So that would be a category C. All right. Scenario 2, 37-year-old patient diagnosed with an infection for which amoxicillin and clavulanate potassium or Augmentin is a clinically reasonable choice. If you have to remember the brand name for Augmentin, just remember that it's augmented with clavulanate. So that's the way I remember it. Augmentin is a clinically reasonable choice. The patient used amoxicillin and other antibiotics in the past without adverse effects. Prescriber ordered Augmentin 500 every 12 hours. After taking 3 doses, the patient experienced a rash and facial swelling. Mind you, this is kind of me, right after the sulfa allergy. He was transported to the emergency department and treated for anaphylaxis. All right. Did an actual error occur? Nope. Why? Because it was not preventable. So there was no error that occurred. There was nothing that could have been known that was not known because the person didn't know that they were allergic. All right, last scenario. 74-year-old female with an acute leg pain presented to the emergency department. She has a history of sleep apnea. She has no previous history of opioid use. Prescriber ordered hydromorphone. What's the brand name for hydromorphone? Dilaudid. That's how I remember it too. Vitamin D. Hydromorphone 4 milligrams IV. That's a whopper of a dose, by the way, from a morphine MME equivalent. Patient was found unresponsive in respiratory distress. That's why I put no history of opioid use. If you just go off the bat and get 4 milligrams of hydromorphone IV, that is punching you metaphorically and literally in the face with opioids. And you will have this happen to you if you are not previously sensitized to them. Low oxygen levels. Naloxone was administered to reverse the effects. However, she was not hospitalized. And obviously, she did not die. All right, so did an error occur? Yes. Did the error reach the patient? Yep. Did it result in the patient death? Nope. Was the patient harmed? Yep. Did the error require an intervention necessary to sustain life? Yes, it did. Was the harm permanent? No. Category H. Bam. So, on the exam, I will not be giving you the flowchart, but I will be giving you the wheel. So that is the way that we have done it, and that's the way it is on Applex, actually. So I think that's pretty fair. What you look at, go back to the wheel. The wheel has the facts in it. It has the definition of it. So you have to do your own flowchart of the information in the case and then where it fits in the category. I won't make them vague. So if you are finding yourself questioning when you're on the exam, you're overthinking it. What I mean by that is don't rewrite the items. And this is a general test taking strategy. Generally, in a case, the information you need is on there. For example, if it says that the patient is female and it does not say the female patient is pregnant, they're not pregnant. Because if it said they were pregnant, then it would be relevant for the case. If you say, but they could have been pregnant, you have rewritten the item to say that the patient was pregnant. When you are looking at an item on an exam, think about whether or not you are putting information in the item that was not there, or if you are rewriting it. Every time, to a point, when a student comes and challenges me, they begin with, well, but what if? And I have to say, what are you doing? You are rewriting the item because you're asking yourself a question that could not be answered by what was provided to you. And therefore, it is information that you did not need to answer the question. So if I said, for example, no further harm occurred, I did not say that they did not die. But did they die? Because I didn't say they died. So you have rewritten it if you're having to ask yourself the question, did they die? Information you need is in the case, all right? Questions? Yes? Now, I don't know that. What I'm saying is the wheel is eligible to be on the NAPLEX. I don't write items for the NAPLEX. Let me be transparent about that. Students came back and said, Dr. Malcom, thank you for the NCC MERP stuff. And I'm like, why? And they said, the wheel. I'm like, okay. All right. I like that. I like that because that reinforces what I'm doing here. What I meant by that is generally the information you need, again, is in the case. It's a case-based question, so that's like all in the case, and you're having to pick whichever category it is. So what I'll have you do is it'll be fill in the blank, and you have to put like H, I, D, whatever it is. You'll just have to pick the category of it. It's not going to be multiple categories. It's not going to be I need more information categories. So if you find yourself asking yourself that question, then go back to the item. You have rewritten it. You either picked up too much or not enough from the item. Questions? Okay. Take just stuff. Read the syllabus, do the attestation, watch the documentary. To Err is Human, do the attestation before class next week. And then otherwise we'll see you next Tuesday. Man.
It's raining.
A lot. Already.